All right, here we are. It's time for another one. Maternity, 6th edition, Leafer. Just lost my page. Fuck. All right, we're going with chapter 23, and that would be the child with sensory or neurological condition. And since we're going on sensory, we're going to start out with the ears. We already kind of talked about the ears a little bit. Big issue with the child's ears, especially an infant. They're very susceptible to middle ear infections, and this is all basically because the eustachian tube, it's shorter, it's straighter, and it's wider than a mature eustachian tube. So they're definitely prone to infections. Typical signs of ear infections for a kid would be doing a lot of rubbing or pulling at the ear, rolling the head from side to side, kind of trying to get a little bit comfortable, maybe trying to get them to pop, because that's something that you usually feel like you need to do when you have an ear infection. Hearing loss, loud speech, which also would go hand in hand with the hearing loss because they can't hear themselves speak, so they speak a little bit louder. Inattentive behavior, because they don't hear you. Articulation problems would be kind of go along with your speech. There would be a little bit of an issue speaking words clearly, and speech development problems. So those are some of the common things that would be a good sign for an ear infection. Now, when you have kids who have chronic ear infections, there's a procedure that they would have called a laryngotomy, and it's basically an incision into the eardrum where they insert a tube. It's a small, little, teeny tiny tube. It's millimeters in length, single-digit millimeters, and it's even smaller in width. And that's basically inserted into the eardrum just to make sure that you don't have any tympanic rupture. And it's also called, where is it? Hang on here. It's the laryngotomy, and it is also called, wow, watch me go. I suck at this. I lost it. I hate it when that happens. But anyway, laryngotomy is actually the term. So that would be a surgical intervention that would be done for chronic ear infections. Then you move on to hearing impairment, and this is basically kids who are hard of hearing. It can be congenital disease can cause it. It can be the constant ear infections over and over could eventually cause scar tissue on the tympanic membrane and cause the child to be hard of hearing. So when you're dealing with a kid who's hard of hearing, this is not to be confused with a kid who's deaf. Obviously, it's a little bit different then. But when you're communicating with a kid who is hard of hearing, you're going to do the same things you would do with an elderly patient who's also hard of hearing. You want to be at eye level. You want to maintain eye contact. You want to make sure that eye contact is coming back at you, because establishing eye contact shows that you're both paying attention to each other and you're here for the conversation. You want to talk in short sentences, and you want to avoid using exaggerated lip or face movement, because believe it or not, even at a young age, kids learn to lip read very quickly, especially when they can't hear so well. So that's how you want to do your communication with hearing impaired child. Eye contact, face to face, talk in short sentences, and don't use exaggerated movements with your mouth. When you're going to completely hearing impaired, which would be deaf, then you would be looking at things like sign language. You could do picture communication, and you could go written language and communication back and forth. Now, another issue that can happen on a regular basis to infants, again going back to the not quite full development of the inner ear, is barotrauma, and baro means pressure, right? So barotrauma would be like if you're going up or down a big hill and your ears pop, or your ears would normally pop, sometimes they don't. Or if you're in an airplane and you're ascending or descending, you have the same issue. You're trying to get your ears to pop. And the way to kind of combat that in kids and adults as well would be to have them constantly try to yawn, which actually flexes that muscle that equalizes the pressure inside the ear. Have them chew gum, because the swallowing will actually flex that same muscle. So that's how you prevent barotrauma. So now we're going to move on to eyes. Obviously, the eye is the organ for vision, and if you would test the eyes, basically with Snellen chart is your quick basic way to test eyes and visual acuity. There's also a Titmus machine. It's often used for school age kids. A lot of you guys might remember it. It's that big, giant, ugly beige thing with the pad that you put your forehead up against, and these weird goggles flip down, and all of a sudden you see these different screens that pop up. It's kind of similar to the Snellen test, but they do it for color cues as well. And they also have another machine that does your peripheral vision. That's a little bit further in. So the one thing that you want to remember with an infant, because you want to be able to test vision and visual acuity. So at birth, an actual alert infant will, they'll be active, they'll be making noises, they'll be kind of looking around, and whether or not they see, you can't really tell. But when you give visual stimulus to a newborn infant, a newborn baby or an infant, they'll actually stop and they'll get still and they'll just start watching. So that's how you know they can actually see and they can see what's going on. That's usually a good giveaway. The ability for them to focus and follow objects, you kind of do the same thing that you would do with a neuro check with a patient. Have them follow your pen or have them follow a light. You want to document all that stuff, and you want to make sure that you're getting good eye coordination. So you have some disorders and dysfunctions of the eye. One of them that's actually looked at as a dysfunction of the eye, but it's really not, is dyslexia. And dyslexia is basically, it's a defect in the cortex of the brain that processes your symbols. So the eyes themselves may work perfectly fine, but the brain flips the images around in their head. That's why you get kids with dyslexia have a hard time learning to read. The brain just flips letters back and forth. That's why you'll see a kid who typically is trying to draw a lowercase b will always draw a lowercase d. Really confuses the hell out of them. So they have a harder time learning to read. Typical treatment for dyslexia just involves remedial instruction, which is just constant practice, practice, practice until you can get the brain to relearn or learn the right way how to process the signals that it's getting. And then you've got amblyopia, which is lazy eye, and that's basically a loss in movement of that eye. It's that one eye, and you'll notice it especially if somebody who has it, when they're more tired, it'll happen, even if they've had treatment over the years. And typical treatment for amblyopia is basically to take an eye patch and put it over the good eye, and the good eye gets to take a coffee break for a while. Well, the lazy eye has to do the work, and it has to focus and get more used to doing it. So eventually, the goal, the outcome is for both eyes to be working together, so that you don't have the lazy eye. And again, you can always tell somebody who had a lazy eye when they're a kid. If they're really drunk or really tired, that eye will go. It's a dead giveaway. So then we move on. We've got strabismus, which is the cross eye. One thing that you want to remember about strabismus is it can happen occasionally up to the first 6 weeks of life. It happens naturally. It's because the eye muscles are not coordinated yet. They're not developed yet. So it's not uncommon to see that happen here and there. And you'll see it if you've ever been around a newborn or just a couple of week-old infant. It's very common. And it goes away. But when it doesn't go away, you basically end up, the way it works is the eyes do not coordinate together. So, excuse me, the eyes won't work together, and we have what's called stereoscopic vision, which means we get our depth perception from both of our eyes looking at the same thing, and they're two lenses focusing on the same thing, and that's actually what gives us our depth. So if you cover one eye, you have a hard time telling how far away something is. And that's basically what will happen, because over time, when when the brain can't process both images, because if your eyes are shooting in different directions, you've got two different images coming into the brain. So eventually the brain will just shut down signals coming from that one eye, from one eye or the other, so that it can actually still focus and at least get a general picture of things. Another thing that's very common with strabismus is double vision. And when double vision happens, you can usually tell because you have a child. Double vision, by the way, is called diplopia. That's double vision. Double vision, diplopia. And you can tell when a kid is having that issue because they'll tilt their head to the side a little bit because it makes them feel like they can focus a little bit better. So that's a pretty common giveaway. Squinting is another one, frowning to focus. Missing objects that are reached for, again, because you don't have that depth perception, so you can't tell how far or how close something is. And they'll cover an eye to be able to see a little bit better. And then you get your dizziness and headache, which is common amongst a lot of things like eye strain and stuff like that. You also have hyperopia, which is farsightedness, and myopia, which is nearsightedness. So just remember, myopia, my nearsightedness, and hyperopia is hyper stuff goes further. So hyper is far, and myo is nearsighted. So, and this is usually just corrected with glasses or contact lenses later on. Going back to the eye strain, we kind of touched on that a little bit. You get dizziness or headaches. That's a big one. Short attention span, aching and burning of the eyes. You'll see a lot of squinting, and having a hard time to focus on schoolwork or reading, and or just blackboard. A good thing that helps prevent eye strain is having good lighting, and not having glares in the environment, and make sure that your chairs and your desks are at the right height. And again, you got to give your eyes a break. They're working a lot, especially us as students. We're constantly reading. Most of the time in bad light, and most of the time overtired. I know that's the case for me. So, eye strain is something you can definitely avoid, and you don't want to keep prolonging yourself to it. So we're moving along here into the eye afflictions and issues. You have conjunctivitis, which is pink eye, and we kind of went over that in our review. That's the inflammation of the conjunctiva, or the mucous membrane that lines the eyelids. And pink eye is typically infectious and very contagious. So you really don't want to be too close to somebody who's got pink eye, obviously. But you can get antimicrobial therapy for pink eye. It can come in the form of drops or oral medication. If you're doing drops, we kind of touched on it in the last chapter, in chapter 22. When you're doing drops, you want to pull the lower eyelid down, tilt the head back, and you want to get the drops down into that conjunctival pocket. And when you wipe your eye, you always want to wipe from the inner area of the eye and wipe outward, away, in the opposite direction of the unaffected eye, because we don't want to wipe it across one eye and get it into the good eye. Always want to make sure that you're teaching good hand hygiene to parents and kids when pink eye is involved. And when you do get your antimicrobial therapy, when you start taking medications, after about 20 hours of taking your medications, you're no longer contagious for pink eye. So 24 hours, that's the magic number. Okay, and hyphema, that's the presence of blood in the anterior chamber. And basically it's usually a blunt force trauma type of thing. Sometimes it can come from extremely elevated blood pressure, believe it or not. And that's basically broken blood vessels in the eye. And eventually it goes away. You can get topical medication for it, which would be drops. You can get creams also that would go into the eye. And treatment for that, another intervention for that would be to keep the bed in high Fowler's position, 30 to 45 degrees. Let's see, moving along, let's get into the nervous system a little bit. We know that the central nervous system is basically, it controls everything, controls all of your motor functions in the body. And there are a couple of quick ways to do a CNS check, do a neurological check, and that's the check with the eyes. You put the light in the eyes and you make sure that you have PERLA, right, which is pupils equal, round, reactive to light, and accommodation. You want to make sure that they're both working together. If you've got one eye that's dilating or constricting and the other one's not, there's a sign of neuro damage there. Other signs, other tests for neuro would be the push-pull-squeeze with the hands. With the feet, you have them push or pull with their feet as well. And anything that's not bilateral as far as effectiveness, that's going to usually be a dead giveaway that there's some sort of CNS issues going on. So Reye's syndrome is one of the ones that we're going to get into a little bit. And Reye's syndrome is basically an acute non-inflammatory encephalopathy. Okay? So it's non-inflammatory brain pathology, and it also affects your liver too. The way you want to, the most common way that Reye's syndrome is acquired is by giving kids aspirin or other medications that contain salicylates with when they have flu-like symptoms or a fever. So you want to make sure that you're not giving that. No aspirin and no salicylates with fever. Manifestations of Rye syndrome, manifestations will come out in increased intracranial pressure. And increased intracranial pressure is going to be a lot of the same things as if you had a concussion, because you're putting pressure on the brain, you're causing dysfunction in the brain. So you're going to have nausea, vomiting, altered behavior, lethargy, altered level of consciousness. And a lot of these after a viral illness is definitely a sign that you may want to be getting checked out for Rye syndrome. Have the kid checked out. In infants, you get diarrhea, hypoglycemia, tachypnea with apneic episodes and seizures. And that's usually about 1 week after a respiratory illness. So once the kid stops showing signs of being sick, it doesn't mean they're out of the water, especially if you're giving aspirin. You never want to do that. So your treatment for that is basically going to be frequent assessment of vital signs and careful neuro checks. Careful neuro checks. You're also going to look for signs of bleeding because liver dysfunction is involved in Rye's, and it can cause blood clotting abnormalities. So you can end up bleeding. You get gingival bleeds and stuff like that. So we move on a little bit to infections and systemic infections. It's called sepsis, and that's basically when the entire body is poisoned. Children who are immunocompromised, have neutropenia, or in ICU recovering from invasive therapies are at the most highest risk for developing sepsis. So signs and symptoms that you want to look for in sepsis would be fever, chills, tachypnea, tachycardia, and neurological signs such as lethargy. And one thing you want to remember with septic shock is not diagnosed by a decrease in blood pressure, because initially the body will elevate its blood pressure in order to compensate. It's the compensatory mechanism. If you do get to that point where the blood pressure is lowering, that's a bad sign, because at this point your compensatory measures are not working and the body is going, I got nothing. So when the blood pressure drops after sepsis, you're usually looking at cardiac arrest coming very close behind that. So now we move on to meningitis. Meningitis is an inflammation of the meninges, which is the covering of the brain and the spinal cord. And we talked about this a little bit in the review. And peak incidence for bacterial meningitis is between 6 months of age. It's very readily transmitted, very contagious. So child is going to be placed in isolation until 24 hours after your antibiotic therapy has been initiated. It's kind of the same thing as pink eye. At least a day of medication therapy before you can not worry about contagious. In severe cases of meningitis, you get arching of the back caused by muscle contractions, and I suck at this word, opisthotonos, and it basically is just the arching of the back. It's the kid could be laying on their back and the back won't even be touching the mattress because they're arching their back so much, and that's the pressure on the brain sending the signals for the muscles to contract, and you just arch the back. So that's usually a very bad sign, and it's definitely a neuro issue. So your nursing care is going to be frequent neuro checks. You want to make sure that there's not a lot of stimuli in the patient's room at that point, because it is neuro, we are CNS, and the more stimulus, the more signals, the more synapses, the more activity is going on in the brain, and it's just too much and everything will just start cross-firing or misfiring. So you want to keep your stimulation at a minimum. You don't want to disturb the child when you're doing what you want to do. You want to go as least invasive as possible. The other thing with your vital signs is you want to look for a slowed pulse rate, irregular respirations, and increased blood pressure. Those are reported immediately. So with meningitis, slowed pulse, irregular breathing, and raised blood pressure, report immediately. Raised blood pressure, report immediately. Slowed pulse, say something immediately. Irregular respirations, let somebody know immediately. Now we get into encephalitis. And encephalitis is basically inflammation of the brain. It can be an aftermath of disorders such as upper respiratory tract infections, German measles, which is rubella, or measles, which is rubeola. Um, or it can rarely, in some cases, it can be a reaction to um, vaccinations like diphtheria and pertussis and tetanus. Not very common. Um, so encephalitis, again, you're having a lot of the same symptoms that you would have with concussion. You get a CNS response. There's going to be headache followed by drowsiness that can proceed to a coma. Because the coma is sometimes prolonged, encephalitis is sometimes referred to as sleeping sickness. It also can manifest itself in seizures, fever, cramps, abdominal pain, vomiting, stiff neck, delirium, muscle twitching, and abnormal eye movements. Again, all of this along the same lines of a concussion. Are we sensing a pattern here with neuro? Okay, so the one thing that nurse is going to want to closely observe the child for is neuro changes. Fatality rates and residual effects are higher among infants than they are among other children. Speech, mental processes, and motor abilities may be slowed, and permanent brain damage and mental retardation actually can result from encephalitis. So, that's no bueno. Brain tumors, right along the same signs and symptoms. Thing with brain tumors is it's directly related to the size of the tumor and where it is in the brain, because different parts of your brain are going to affect different things, obviously. Couple of the hallmark symptoms or signs of intracranial pressure are your headache, your vomiting, your drowsiness, and your seizures. Again, concussion-like symptoms. You get nystagmus, which is constant jerky movements of the eyeball. That's when the eyes will just keep moving and they'll try to focus. It's almost like the same thing. When you're a little kid, you spin around, and then when you stop, your eyes are going, and they're moving, and they won't stop. So that's nystagmus. And then you get papilledema, which is edema of the optic nerve. So other symptoms would kind of go along with strabismus, with the cross eye, the head tilt, ataxia, behavioral changes, and cerebral enlargement. You get your anterior fontanelle enlargement in infants. So treatment for that would basically, or diagnosis would be CT, MRI, and EEG. Treatments would be radiotherapy, chemotherapy, or surgery. May even be part of the regimen going on. When you've got a pre-op patient, a little kid, again, it kind of goes with involve the parents, communicate everything you can, make sure that the kid has transitional objects with him, like a favorite doll or a favorite blanket. You know, if you're going to have that wound, that surgery, and the kid is going to have a bandage, you can take the doll that the kid has and put a bandage on the doll in the same spot. Kind of helps a little bit with coping of dealing with the anticipation of that. Post-op is a little bit different. A lot of times they're going to come in with a hypothermia blanket, a cooling blanket, or a mechanical respirator, and you want to prepare the parents for the appearance of their child after, well, prepare the parents for the appearance. America. You want to prepare the parents because that child is definitely going to not be the same kid that they walked into the OR. So it can be just as traumatic for the parents, if not more, than it can for the kid. Kids are pretty tough. Parents, we're not so tough when it comes to our kids. When radiation treatment is prescribed, the radiologist will outline areas to be treated on the child's head. It's important you don't wash these marks off because it's got to start all over again, got to remark everything, so leave the marks there. Okay, and again, going back to your concussion-like symptoms, sluggish or dilated or unequal pupils may indicate increased ICP and must be reported promptly. So now, again, with our ICP, or increased intracranial pressure, we get into seizure disorders because seizures can come along with that. We start out with febrile seizures. Febrile seizures are not really so much of an ICP thing. Febrile seizures are a response to a rapid rise in temperature. So fast rise in temperature, febrile, fast rise in temperature. And that's where you get your febrile seizures. Typically between 6 months and 5 years of age. Let's see, and then we have epilepsy. Epilepsy is basically, it's manifested by a variety of symptom complexes. It's recurrent paroxysmal attacks of unconsciousness or impaired consciousness. So basically, epilepsy is chronic recurrent seizures. The one thing, a couple of things that the nurse is going to observe and record is the child's activity immediately before a seizure, body movements, changes in color, respiration. There are things that the body will do and will kind of give away signs that a seizure is about to happen. Things will start to get a little herky and jerky before they actually go. Then you get into your generalized seizures. In your generalized seizures, you're going to see, and the patient will have what's called an aura, and they'll hear beating of drums in the background. I kind of hear drums right now. Sounds like hip hop. All right, so beating of drums in your aura are usually dead indicators that we're getting ready to have a generalized seizure. And you have your petite mal seizures. Petite mal seizures are a little bit more subtle. Basically, they can be mistaken for daydreaming. You can have a blank stare, rapid blinking and chewing movements of the mouth are a couple other signs of petite mal. And the thing about a petite mal is the kid doesn't know it's happening, and it typically will happen in children. It can be mistaken for daydreaming or lack of attention. So some of your diagnostic measures would be skull radiography, CT, MRI scans. Those are used to establish the presence of tumors and skull abnormalities that may cause seizure disorders or even hematomas. And your EEG is also a valuable tool in diagnosing seizures. So in epilepsy, we have treatment with seizure disorder medications. And there is a whole laundry list of different medications for seizures. One of your most common one is going to be Dilantin. And the one thing you're going to remember with Dilantin is extended use of Dilantin will actually give you gingival hyperplasia. So you want to make sure that you're having good oral care when it comes to that kind of stuff. You can also have a ketogenic diet, it's called, and this is sometimes prescribed for kids who have seizure disorders. And basically, it's for kids who don't respond well to the anticonvulsant therapy. Now, the ketogenic diet is high in fats and low in carbs, and it's got adequate protein. Basically, it produces ketoacidosis in the body, which somehow reduces convulsive episodes. Also, a reduction of fluid intake. Not necessarily fluid restriction, but you want to make sure that you're not overhydrating. So reduction of fluid intake also increases that ketogenic effect, which again helps fight with those episodes. The problem with that diet is it's boring, and kids want to have their diet, and kids don't eat like a ketogenic diet is prescribed. So compliance tends to be an issue with kids. In some states, they don't allow anybody who has controlled epilepsy to have a driver's license. In other states, it's usually a certain amount of time in between episodes. So I believe in Jersey, it's 6 months without any seizures before you can get your driver's license back. If you have your driver's license and you get a seizure, guess what? Buy a driver's license. They take it away. One thing is restriction of physical activity is not necessary. So you can let kids do whatever they want to do. However, things like tree climbing, swimming, or being in the bathtub, you definitely still want to leave them, you don't want to leave them unsupervised, because if they do happen to have a seizure in one of those situations, bad things can happen. So then you get into status epilepticus. Status epilepticus is basically full-on seizure that lasts more than 30 minutes. It can result in brain hypoxia, and a common cause of it is basically sudden stopping of anticonvulsive medications. So, like most medications, we don't want to just suddenly stop. If we're going to get off that medication, it's going to have to be weaned down by your doctor. So now we move into cerebral palsy. Cerebral palsy is a term used to describe a group of motor disorders caused by dysfunction of various motor centers in the brain. Basically, it affects your movement, your posture, and it causes a lot of activity limitations. In severe cases, you can end up with just complete dysfunction of the limbs, which can lead to contractures if you're not doing preventative interventions with that, like passive range of motion, stuff like that. Other manifestations would be in infancy, you would have feeding problems, seizures that aren't associated with high fever, developmental delays, and developmental milestones. Basically, in your delays, your milestones aren't reached at that point that they should have been reached. Sometimes they don't get reached, sometimes it could be a couple of months to a year later. Um, Spasticity is a big one. You get tension in certain muscle groups. Muscles will flex up on you and twitch on you. You get jerky motions when you're trying to perform basic motor skills. Um, the legs can cross, the toes can point inwards, and we'll go into that, the positioning for that in just a little bit. But as far as your nursing care goes, you basically you want to remember that these patients do have psychosocial needs, and you want to basically focus on the assets that the patient will have, because the patient will look like they are completely not functional. You don't want to be misled by the appearance, because the intelligence is still there. So you don't want to treat the child or the patient like they're intellectually inept, because the brain is still there. It's just the physical motor skills that are being affected. You want to make sure that you give good skin care, because people with cerebral palsy eventually are going to end up in wheelchairs, so there's going to be repositioning. There's risk for pressure ulcers and stuff like that. Feeding problems are also another issue, especially in young children. The problem with it is swallowing and sucking is difficult, and vomiting is common because the gag reflex is actually overactive. So it's not so much of a risk for aspiration, where your gag reflex is normally dulled. The gag reflex is pretty much anything that touches your mouth, it's going to make you gag. It's a hyperactive gag reflex. So you usually end up with G-tubes in patients like this. So now we move on a little bit into cognitive impairment. And cognitive impairment is basically a term that encompasses any type of mental deficiency or mental retardation. So mental retardation, going on to that. Mental retardation basically, first off, mental retardation is actually the specific terminology that's most often used. It's mental retardation or cognitive impairment. You get your schools and stuff like that where they use mentally handicapped, mentally deficient, mentally disabled, mentally impaired, or mentally challenged, or politically mentally correct. Yeah, it's mental retardation. That's actually the term. It's not something that is an offensive thing. It's the term. That's how it's used. You have basically 4 levels of your classification of mental retardation is based on 4 levels of support system needed for your ADLs. So your need for intermittent support, your limited support, extensive support, or pervasive total support are your basic levels of mental retardation. And again, mentally retarded children are just like children with CP. They have psychosocial needs. You want to work on your growth and development together with the child, and you want to keep things on their level as far as learning and education. And it's important to remember that you have to correlate your developmental milestones with the mental abilities of the child, because that's obviously going to be lagged and delayed. So there's quite a few causes of mental retardation. Phenylketonuria, hypothyroidism, fetal alcohol syndrome is a big one. Usually ends up in a more mild retardation. Down syndrome and malformations of the brain are a couple of big ones. Some maternal infections will also cause it. And also birth injuries can cause mental retardation. So again, with your nursing tips, you want to remember cognitively impaired children have the same psychosocial needs as all other children, but can't express themselves or respond as other children do, so you need to treat them accordingly. Mentally handicapped child needs to have a sense of accomplishment, and it's basically the same thing as if you have a 95-year-old patient who, whatever independence they can have, you want to encourage that independence, encourage that growth, and you want to praise that. You want to emphasize their strengths. You want to maintain communication with the family. You want to avoid labels. Just because we use the term mental retardation doesn't mean we call the kid retarded. You want to use simple terms. And you also want to be in touch with the school nurse and do your interdisciplinary care plan there. So now, I know I mentioned it numerous times before, concussion. Concussion is basically a temporary disturbance of the brain that's followed by a period of unconsciousness. And it's basically the brain being jarred. And it's usually followed by blunt force or a baby shaking. And baby shaking, in shaken baby syndrome, it's basically the brain strikes the inside of the skull, which causes your concussion. But in shaken baby syndrome, it also causes the tearing of nerve fibers within the brain. So you can result in retinal, subarachnoid, and subdural hemorrhages. Classic symptom or classic sign of baby shaking is actually torn retina and bleeding inside the eyes. That's usually a dead giveaway because everything is still so fragile. Along with that, you can get your intracranial pressure increased, and you get different posturing. You get your decorticate, which is your flexor posturing, and decerebrate, which is your extensor posturing. So you've got your flexor posturing, which basically pulls the hands up. That gives you that nervous, like wringing your hands across your chest kind of look. Whereas your extensor posturing makes the arms shoot straight out. Excuse me. So you get the extensor, which basically shoots the arms straight out, and it actually makes the hands curl up at the wrists. So you want to look for signs of increasing intracranial pressure, especially after a shaken baby incident. The 4 basic symptoms are level of consciousness, pupil and eye movement, again with PERLA, your vital signs, and your motor activity. And those are things that you want to look for and want to watch for changes. Again, all along the same lines of a concussion. Vital signs as far as ICP: an increase in blood pressure, a decrease in pulse and respiration are evidence of increased intracranial pressure. So, intracranial pressure, you've got pressure on the brain. The pressure increases your blood pressure. It decreases your pulse and decreases your respiration. And then we have near drowning as another cause of neurological conditions. Near drowning is basically defined as survival beyond 24 hours after submersion. So near drowning, obviously you did survive. Excuse me. So with near drowning, you do have, you basically have asphyxiation. You cut off oxygen to the brain, and this can cause CNS injury. And that usually is the result of the death in near drowning. And that's basically it on this chapter. That's chapter 23, sensory and neurological conditions. And I hope this helped you, because it's definitely helping me. And keep on nursing. See you next time.